Good evening to all of you. My topic of discussion today is RA strategy for diabetic foot debridement. So, as we all aware that diabetes is a chronic multisystemic disease with a global prevalence of 9.3%. What we have should be concerned is that patients who are coming for surgical procedures, 20% have diabetes, and diabetic foot prevalence would be around 25%, and among them, 1.8% are posted for amputation surgeries. And with the literature, it says that regional anesthesia do have a documented benefits for early restoration in such group of patients. Coming to the pathophysiology, what we have to understand in pathophysiology is that there is some amount of metabolic disturbances occurring in diabetes. There is hyperglycemia, oxidative stress, which leads to cellular level mitochondrial defect, and also sodium potassium channel activity disturbances. All these leading to a axonal injury, demyelination, structural and functional abnormalities. So such patients have symptoms like tingling, numbness, and paresthesia, which has to be documented and understood prior to during our pre-anesthetic checkup when patients are admitted for surgery. Two things which we have to understand in diabetic peripheral neuropathy is that there is a bioenergetic failure. That means these nerve cells, they lose the ability to produce ATP, which leads to like cell damage. And there are a lot of other metabolic disturbances like inflammation, oxidative stress, underlying microvascular damage. There is a cellular level mitochondrial dysfunction. So all these things progressing from distal to proximal degeneration, leading to nerve dysfunction and cell death. So earlier it was understood that only hyperglycemia led to such cellular injury, but now we know that there is dyslipidemia, obesity, insulin resistance, along with that these intrinsic caspase pathways which are activated, which leads to further inflammation, oxidative stress, forming a vicious cycle which progressively is leading to nerves dysfunction and cell death. We need to understand that why in diabetes this diabetic foot ulceration is much more common. So for that we know that there is patients are in prolonged hyperglycemia, so there is a collagen disorder. The cells repairing mechanism is lost, so there is defective wound healing, and they have underlying sensory motor dysfunction. So the repeated trauma goes unnoticed. Autonomic disturbances, so there is dry skin, skin fissuring, repeated infections, and underlying peripheral arterial disease. So all these things leading to increased oxidative stress, inflammation in the lower limb, and ischemia, all leading to diabetic foot ulceration. Now, why do the literature demands that regional anesthesia has some kind of added benefit in diabetic foot or diabetic patients? So there are a lot of meta-analysis which came into picture, saying that like in this study, lower extremity amputation, like patients posted for lower extremity amputation, high-risk patients, general anesthesia was associated with increased risk of respiratory failure and sepsis compared to regional anesthesia. And also in this study, they say they propose that like peripheral nerve blocks had a stable intraoperative hemodynamic and superior postoperative analgesic effect.
दो मैप हैं
So, so now why we should avoid general anesthesia in diabetes is that in diabetic patients, they are having some amount of collagen disorders, which leads to stiff mobility syndrome, and they do have unanticipated difficult intubation. And using a RA technique, we are we are having an opioid sparing mechanism, so that will decrease all the adverse opioid effects like ventilatory impairment and opioid induced nausea, vomiting, constipation. Patients are diabetic patients are having gastroparesis, so they are prone to delayed gastric emptying. Giving a regional technique, again making them leading to rapid diet restoration and promoting early mobilization, so decreasing the incidence of any food ulcerations or hospital acquired sarcopenia. What are our regional anesthesia options? So first we have central neuraxial techniques like spinal epidural, combined spinal epidural. Literature review. So article had this article had proposed that they had used spinal anesthesia for diabetic foot surgery. They used 0.25% hyperbaric bupivacaine, and they found there were no profound hypotension. After giving spinal anesthesia, patients were maintained in sitting position for 10 minutes to confine the sensory blockade on the lower level. So the salient features in this article was that all the long-standing diabetic patients have underlying autonomic dysfunction and sensory motor neuropathy. So that had increased risk of further neurological sequelae after central neuraxial blockade. So they wanted to create a balance where using a lower concentration of drug helped in such patients to undergo the surgery, but at the same time reducing the toxic effects of local anesthetic agents. This was another study which showed that how central neuraxial blockade decreased the catecholamine and steroid release. So that helped in attenuating the stress response to surgery. So there were fewer hyperglycemic episodes both in diabetic and non-diabetic patients. Now, when and why we should avoid central neuraxial blockade? So, as we are aware that diabetic patients have autonomic neuropathy. And so long-standing diabetic patients have underlying coronary artery disease, cerebrovascular disease, and renal disease. So profound hypotension can lead to deleterious consequences in such patients. Also, higher chances of infection, so epidural abscesses following spinal and epidural anesthesia. Now, other modalities would be a peripheral nerve block. So we have quite a good amount of options like femoral nerve, adductor canal, popliteal sciatic, and angle block. So we need to use a permutation combination of block has to be tailor made depending on our area of interest of surgery. Now looking at the innervation, if you look at the cutaneous, muscular and bony sensory distribution, mostly it is covered by the tibial and the common peroneal nerve component, except that in sensory distribution, we have the saphenous nerve which is covering the medial aspect of the leg. What are the modalities to be chosen? So we have the landmark neurostimulation and ultrasound guided. What are the concerns with neurostimulation and why? There were a lot of research studies which showed that electrical stimulation threshold was higher with patients with underlying motor neuropathy. So there were 1.3 milliampere used versus 0.5 milliampere in control subjects. Also, they found that there was difficulty in nerve localization and intraneural needle placement in PNS guided and ultrasound was recommended for this. And also the pharmacokinetic and dynamic mechanisms contributed to the overall phenomenon of prolonged nerve block duration. Now, why is ultrasound preferred? So, there were different studies which were postulated and showed that nerve stimulation may not be the ideal way of helping us in guiding for block guidance in diabetic patients. And we required higher stimulation threshold in diabetic patients, which led to higher chances of intraneural needle placement or failed blocks. So, as a result, ultrasound guided blocks were increasingly recommended. Now, what would be the optimal block site? So we would go step by step. Now, for a distal foot without cellulitis, we can go with the angle block.
What is that?
Uh, for a foot inner, now we are looking at the nerves which supply the foot. Basically, we have five nerves. One is the superficial peroneal nerve, the deep peroneal nerve. Then we have the saphenous nerve and the sural nerve, and also the tibial nerve, which is covering the medial malleolar aspect of the foot. Uh, Coming to the angle block, so tibial nerve, we would use a high frequency linear probe placing transversely between the medial malleolus and the tendoachilles. What our area of interest would be, we need to find out the tibial artery, and the tibial nerve lies adjacent to it. For a deep peroneal nerve, the probe is placed on the anterior aspect of the angle. We have to identify the anterior tibial artery, and the deep peroneal nerve lies lateral to it between the tibialis anterior and extends the hallucis longus. Superficial peroneal nerve, the probe is placed around 10 to 15 centimeters proximal to the lateral malleolus, and probably the superficial peroneal nerve has to be seen between the peroneus brevis and extensor digitorum longus. For sural nerve, the probe is placed between the lateral malleolus and the tendoachilles, and we should be able to see the small saphenous vein, and the nerve lies adjacent to the small saphenous vein. For saphenous nerve, the probe is placed in a transverse orientation beside the medial malleolus, and we should be able to see the saphenous nerve next to the saphenous vein. Coming to the next, if it is a proximal foot with cellulitis, a popliteal with an adductor canal block can be preferred. The popliteal sciatic nerve block can be given prone, lateral, and supine. This is just an ultrasound picture showing the popliteal sciatic block. So we place the probe in about 2 to 3 centimeters above the popliteal fossa, identify the sciatic nerve superficially and laterally to the popliteal vessels, and between the semimembranosus and biceps femoris. So needle is coming from lateral to medial, and we have to locate the local anesthetic agent in the tibial and the common peroneal nerve component when both the nerve components are in the common loca sheath. Coming to the case discussion. So our case one is a 61-year-old female known case of rheumatoid arthritis who had sustained minor trauma to her left foot, but which led to non-healing ulcer. So she was posted for debridement and later for skin grafting. On examination, she was a very frail patient, and rheumatoid arthritis associated deformities were very much apparent in her upper limb and lower limb. Airway appeared adequate. Spine spaces were not easily felt. Investigation wise, her hemoglobin was 7.9. Rest parameters were within normal limits. She was transfused 1 unit of PCV prior to surgery. Our plan was femoral with a popliteal sciatic nerve block. We introduced around 10 ml of 0.5% bupivacaine in the femoral nerve for the femoral nerve block. And for the popliteal sciatic nerve block, 10 to 12 ml of 0.5% bupivacaine was deposited. We can see that there are a lot of edema in the skin subcutaneous plane. So a literature review comparing the popliteal nerve block with ankle block. So it was shown that popliteal sciatic nerve block had a was much more safer and reliable, better perioperative pain management, and decreased opioid requirement. And now coming to the next step, where if it is a below knee joint, then we can go ahead with proximal sciatic and femoral block. So my case two would be a 66-year-old male, a known case of diabetic with ischemic heart disease. He had sustained a fall and had a left malleolar fracture. He underwent fracture fixation with plating under J in outside hospital, but later, probably due to implant infected, he was posted 1 month later for multiple debridements and discharged with an antibiotic cover. Again, 1 month later, he was readmitted with stroke and he was undergoing treatment and rehabilitation. So, on admission, when he was admitted in our hospital, he was conscious, but he preferred to sleep. He was vitally stable. He didn't require any inotropic support. Local examination showed left leg impending cellulitis. And systemic examination, there was right-sided hemiparesis with dysarthria. And also, we were anticipating difficult airway. He had heavy jaw and double chin. Hemoglobin was 6.7. Platelet was 90,000. HbA1c was 8.7. BSL was between 250 to 300 milligram per deciliter. TROP-T was weakly positive. There was some electrolyte disturbances. Creat was raised and BNP was on the higher side. Ejection fraction showed 45% with right wall motion abnormality. In view of impending cellulitis, patient was posted for below knee amputation. For optimization, we had activated a multidisciplinary approach. Patient was in ICU. PCV was transfused to build up the hemoglobin. We started him on antibiotic cover, insulin treatment to bring down the sugars, and cardiologist opinion. Patient was taken up under high risk consent. Our plan of anesthesia was a peripheral nerve block because he was a patient of long-standing uncontrolled diabetes. So we anticipated a patient would have good amount of autonomic disturbances, and also he had underlying other systemic involvement like cardiovascular, renal, and cerebral vascular. So keeping this in mind, we went ahead with peripheral nerve block. So first we gave a femoral nerve block of 15 ml of 2% lignocaine with 0.5% bupivacaine. So again, in this patient also, the patient had good amount of edema. What we have to understand is such patients, there would be anatomical distortion. So we need to administer the drug in a controlled environment. Have to see the proper shaft of the needle tip. Give it an ultrasound guided block so that we don't cause further nerve injury. There is a good adequate deposition of the drug. Sciatic nerve block, we gave a subgluteal sciatic nerve block. We can see that the sciatic nerve is seen between the gluteus maximus and quadratus femoris. So this is the drug being administered, the local anesthetic in the subgluteal space. So this was the intraoperative period. Uh, this is a study which came in IJ, this was to estimate the minimum effective volume of 0.5% bupivacaine in popliteal sciatic block in diabetic patients. So they had a sample size of 53 patients, and they had admitted the patients according to a neuropathic symptom score. So 45 patients had successful block and 8 patients required additional anesthesia. They started with a drug volume of 10 ml of 0.5% bupivacaine. And by the end of the study, they could find out that the minimum effective volume in 90% of patients were 5.85 ml. So their argument was that this low volume helped in successful block administration because it was ultrasound guided, and also there was good visualization of the drug being administered in the subparaneal and circumferential spread of local anesthetic agent. This was another study comparing subgluteal sciatic nerve block duration in type 2 diabetic and non-diabetic patients, and it was found that the medial duration of sensory and motor block was higher in diabetic group of patients. The study highlighted that further research is required to get the best concentration of local anesthetic agents, so that there is a less of nerve injury toxicity. At the same time, we are able to perform the surgery under regional anesthesia. Now, why epinephrine can be worrisome in such patients? So, as we are aware that epinephrine reduces the blood flow in peripheral nerve, but patients who was already having a compromised vascular integrity, they may not be able to tolerate such severe reduction. So, again, reducing the neural blood flow, epinephrine decreasing the washout of the local anesthetic agent. So prolonged duration of the drug around the nerve, again potentiating the toxicity. What about adjuvant? So dexmedetomidine was found to have anti-inflammatory and prolonging the sensory and motor blockade as when given as adjuvant. But at the same time, there was a study which showed that it did trigger neurotoxicity when high dose of perineural dexmedetomidine was administered. Now, trying to understand what is the double crush syndrome. So here we know that this is a normal axoplasmic flow. Here there is a minor insult which has developed in the peripheral nerve, but there is no distal denervation happening. Here there are two minor insults which has led to distal denervation, and here there is axon with a diffuse pre-existing underlying disease process which is causing again impaired axonal flow. So the theory is that patients with such severe neuronal injury underlying so if you administer a local anesthetic agent, there are chances that it can lead to double crush or further nerve injury. But again, there are literature review is pending for how much should be the what all patients are prone for such double crush, what should be the duration of diabetes, and also at what HbA1c should we anticipate double crush syndrome. This study showed the relationship between glycosylated hemoglobin and sciatic nerve block performance in diabetic patients. So, according to American Diabetic Association, HbA1c should be less than 7%. In the study, they had grouped the patient in first group, it was 5 to 6%, group 2 moderate 7 to 8%, and group 3 severe HbA1c between 9 to 10%. Their observation was sensory block regression was longer among patients in group 3, and block performance time was also longer. And there is long-term micro and macrovascular complications were directly proportional to the glycemic control. So patients with underlying diabetic neuropathy had a denser peripheral nerve block, and also in post-operative period, group 3 patients had a longer pain-free period, and this was explained probably due to the underlying loss of myelinated fibers, demyelination seen in diabetic neuropathy. So my key takeaways in this presentation would be that regional anesthesia does offer an array of benefits like avoiding airway complications, early diet, resuming rapid mobilization, attenuating the stress response to surgery, opioid sparing, and all these leading to reduced hospital stay. But at the same time, such patients have underlying metabolic and structural changes. So RA strategy has to be modified. We need to have a comprehensive decision making, which is and with the essential for a proper documentation, having a meticulous aseptic technique, and also modify the technique so that we are mitigating the harm and acquiring full benefits of regional anesthesia techniques in diabetic group of patients. Thank you.
Well done, Reshma. It was a very nice presentation, very
Thank you.
detailed. everything was covered almost.
Yes, sir. Thank you, sir.
Can you tell me, in your second case,
Yes, sir.
you gave femoral block and the sciatic, subgluteal sciatic block.
Yes, sir.
So, is there any other block which you want to add with these two block?
Mm,
Any amputation?
for below knee amputation, any other additional blocks, sir?
Yeah.
With femoral and sciatic, we had covered both the anterior and posterior aspect.
Uh,
So,
One more thing which I want to add here,
huh,
the
yes, sir.
posterior cutaneous nerve of thigh. Okay.
Yes. Posterior cutaneous nerve, the thigh. Yes, in subgluteal, yes, it can be spared. Yes, sir.
It can be spared, and only in up to 5% of patients it,
Hmm.
it it goes up to the popliteal
Uh,
fossa.
yes, sir. And probably next tendo Achilles also their
Yeah.
termination has been seen.
So how can you block this nerve?
Sir, we'll have to go for a more proximal approach.
Or else you can add simple local
Ha, like cutaneous infiltration, sir, on the posterior aspect of the thigh.
and in the popliteal fossa,
Okay,
this nerve lies along with the short saphenous vein.
okay, sir.
So you can block if you can visualize short saphenous vein under ultrasound, you can block this nerve.
Okay, sir.
Okay. And what is the role of catheters, post-operative analgesia? What is the role of catheter for post-operative analgesia in this patient?
Sir, catheter, yes, it does give a prolonged pain-free period for such patient. But again, catheters, we need to have a proper team because again, catheters can increase the infection chances of such patients who are already immunocompromised. So, proper catheter, we need to take care of the catheter, and we should have a good aseptic techniques. Um, and also patients, if they are having a documented like a diabetic neuropathy, again, catheters would prolong their sensory motor blockade. So I have personally not used catheter, sir. So I would feel like give a peripheral nerve block and then cover other modalities with multimodal analgesia, sir.
When the duration of analgesia is very prolonged after the single shot injections in the diabetic.
In diabetic patients, sir. So
So, so do you add dexamethasone along with the local anesthetic for the nerve blocks?
Yes, sir, we do add, but if a patient is a diabetic, then we usually don't add dexamethasone.
What about systemic dexamethasone? Do you give systemic
Mm,
dexamethasone?
Again, sir, systemic also we try to avoid in diabetic patients. Non-diabetic patients, yes, we do had
In
4
diabetic patient,
milligrams of
single shot dexamethasone will not raise blood sugar level too much. Given,
yes,
can be given.
yes, sir. Okay, sir.
And you are a fellow.
Yes, sir.
Okay. So what additional investigation in pre-op area you want to add in this patient, in your patients, all the diabetic patients?
Sir, sir, other than the routine lab investigations and echo,
In
also.
your pre-operative area.
mm, Additionally, sir, there are these certain um, sir, I'm not sure there are these certain tools which helps us in finding out underlying neuropathy in such patients, sir.
Think about that. Um, Actually, in these patients, this gastric emptying is delayed.
Okay, so yes, sir. Okay,
Especially
so
in those
doing a focus.
gastric focus should be done, especially in those patients who are on GLP-1 inhibitors.
Yes, sir.
Suppose your patient is having a long fasting, since around 2 3 days, your patient is not having any meal and is a bit dehydrated. So, what precaution would you want to take in this patient?
Sir, again, we
Talking
will
about,
have to
I'm
hydrate.
talking
We
about,
need to hydrate the patient, no, sir.
I want to talk about a drug. Which drug? How to manage?
S- sir, sorry, sir, I didn't get your question.
Which drug you want to avoid in this patient, especially when your patient is dehydrated and not taking proper meal. Again, SGLT2 inhibitors.
Yes, sir. That shows that it cause it leads to like a state of full stomach, sir.
No, no,
So
no, no.
we have to.
They can cause
Yes.
euglycemic ketoacidosis, especially those patients who are on long fasting or who have ICU admissions. In those patients, ideally this dapagliflozin should be stopped 5 days prior to the surgery.
Okay, sir.
Dr. Manjula, any
Yeah.
questions? Your
Yeah,
side?
and that's an excellent presentation, Reshma. Certain points to be added, when
Yes, ma'am.
this usually will come as a history taking, a diabetic foot for your exams is going to be with the history taking. So all the salient features in your previous assessment should be like, noted down. Some of the things that I
Yes,
just
ma'am.
want to add on is that apart from the pre-existing neuropathy, which has to be documented, we'll also look into whether this is an elective surgery or an emergency surgery. If the patient has come with cellulitis sepsis, it becomes an emergency. Then you really don't bother too much on looking at the glycemic control. Whereas an elective, you have time for the glycemic control as well. Like for your patients, you said that the hemoglobin was low and you could correct them being an elective. So it does matter when you're planning your anesthesia techniques. It also matters what kind of anesthesia you want to choose based on
Yes,
your elective and emergency. Other thing is in diabetic also that we are talking so much on neuropathies, we should also look into the glycemic control of the patient. So normally we
yes,
take it as a first case in the morning, try to make them, go and take the feeds early. Those kind of things are there.
yes, ma'am.
That is one in the pre-op assessment. Okay.
Yes,
So autonomic neuropathy, as you said, you put it down in the slide that autonomic neuropathy is very important because in your regional, when you're looking at central more so, that the patient can have a crash with postural hypertension and weird hemodynamic parameters can result in, which we have to be careful when you're looking at the central neuroaxle unlike your peripheral. In the peripheral, when you were talking in your particular one ulcerative leg that you had, I was just
yes.
wondering why you choose femoral for it. Don't you think there's going to be a quadriceps weakness on that patient? There was some second or third case which had an ulcer on
Yes,
the
ma'am.
lateral.
But anyway, they were not planning to like mobilize her, and so also they were planning to apply high tourniquet. So that is why we thought of femoral. But again, yes, ma'am, she would have had quadriceps weakness, but again, they were not planning to mobilize her because of this debridement, and they were planning a back dressing. So
All right, so that
that
matters.
is why
Like
we.
if they're planning for a tourniquet, the way we give the block will go high proximal. But otherwise, it would have sufficed if you had given a Cephalus, like you said, a rector or
Yes,
and lower
yes,
down near to the common.
yes,
Yeah, that could have sufficed that. Third thing is
yes,
in
ma'am.
diabetic, like BKA, we should always think on post-amputation pain. So we, phantom limb pain, you've heard of it? What is it?
So, no, ma'am, I've not read a lot on phantom limb pain, but yes, post amputation, they have this excruciating pain from the amputated limb, and we have to think about giving gabapentinoids or those group of medications to control the pain.
Yeah. So most of the acute pain can result into chronic pain. So taking care of acute pain actually kind of
Helps you.
it minuses your chronic pain episode. So
Yes,
catheter
ma'am.
infusion, especially for the BKA, helps a
Okay,
lot.
ma'am.
Use of
Okay.
ketamine infusions also helps a lot in the chronic pain. So a word on those things when you're talking on a BKA.
Yes, ma'am.
It's not only about the acute pain, but also how you can extend your regional anesthesia to a chronic pain.
Yes,
Similarly,
ma'am.
so we talked on.
Yes, ma'am.
Due asepsis, like we're talking so much
Yes.
on diabetes and immune system of the diabetes is suppressed. So when now you're doing a regional anesthesia technique, the due asepsis is required. Otherwise, you end up giving increased risk of complications, infective complications.
Yes, ma'am.
I think that is from my side. Any of the
Reshma,
Can I ask something? Shishir, can I ask something? Vandana Mangal here.
ma'am,
yes, ma'am, please go ahead.
Yeah. Yeah. So I wanted to understand if I got it right that for femoral nerve block, you use 2% xylocaine and 0.5% bupivacaine and you use 15 ml of the drug. Did I get it correct?
Yes, ma'am.
So you think that large volume is required for femoral nerve block?
Yes, we could have reduced the drug, ma'am. 8 to 10
Normally,
ml would have
5 to 7
sufficed.
ml blocks the nerve well enough,
Yes,
right?
ma'am. Yes,
So in
correct.
this particular, and the concentrations were, I think, slightly higher for this patient. No?
Ma'am, yes, but this was for anesthetic purpose. If it was for an analgesic purpose, then yes, 0.1 to 0.2% of
No,
ropivacaine would have sufficed.
no. Like in central and
Okay,
axial blockade, you plan to come down to 0.25%. So
okay,
here
ma'am.
also that would have been good enough.
Okay,
That's what I was trying to come to.
okay,
Because we
ma'am.
use 0.5% plain bupivacaine for
Mm-hmm.
anesthetic blocks when we are getting the
Okay,
tibial nails and all done.
yes, ma'am.
Yeah. Thank you.
Reshma,
Okay, ma'am.
one more
Thank you.
question from my side.
Yes, ma'am. Yes, sir.
Suppose your diabetic foot patient, he fell in the ward and he met with the some forearm fracture.
Forearm fracture. Okay.
Forearm fracture. Okay, he got some radius ulnar fracture. So for that purpose, you would like to give supraclavicular block or infraclavicular or axillary block. So would you like to reduce the dosage of the local anesthetic even in supraclavicular block?
Sir, this actually had happened. Like a patient, a diabetic, long-standing patient, he was posted for radius ulnar plating, and I had given, actually by accident, I had given 20 ml of 0.2% ropivacaine, sir.
20
Uh,
ml? Okay, okay.
Yes, sir. And it had acted well. Patient didn't have any pain because as a fellow, like it is my starting stage, so I was anticipating that patient would have pain because I have given a lower concentration of drug. But patient didn't complain of pain, and the surgery went smoothly. Even post-operative also, he was pain-free, and his motor, he didn't have dense motor blockade also, but sensory was covered. So I feel, sir, with 0.2% ropivacaine, if you properly deposit the drug in such patients, we can still do the surgery at the same time reduce the nerve injury.
You mean to say
Uh,
we should reduce the dosage of local anesthetic while we giving some other side block other than.
Sir, like we can, yeah, think of reducing the concentration and give ultrasound guided. So we are depositing the drug in the proper plane.
So very recently, this study was published by Naun Kim. It is a Korean
Hmm.
study
Yes, sir.
who gave axillary brachial plexus block in patients with the diabetes, and
Okay, sir.
the doses required to block the brachial plexus was similar to the normal patient.
Okay, sir.
So it is not always you have to reduce the doses. Yes, sometimes
Okay.
you have to reduce the doses, but not always. And especially
Okay,
when
sir.
you are going to give block at non-neuropathic area, basically.
Yes, sir.
But brachial plexus won't be involved most probably in this patient. Okay.
Okay, sir. Okay, sir.
I think you should consider everything when you're giving a block, the myotome, the dermatome, the osteotome.
Yes,
All of this
sir.
have to be
Yes, ma'am.
considered. So when you're looking at concentration, there's something called as differential blockade, right? So all that does matter. And what you have to remember in diabetic is that there's an increased sensitivity to local anesthetic. And they
Yes,
get,
ma'am.
the more volume you inject, the more they're going to bathe the nerve and prolong the block.
Yes,
So
ma'am.
more less on the volume as well.
Yes, ma'am.
4 पे कर दो.
Hetal sir, you have any other to add on, sir? Any fellows having any questions? Ritesh sir, anything to add on?
Ma'am, there's one question from Suvajit Poddar, Dr. Poddar. Will
Yeah.
femoral nerve block help for tourniquet pain?
Reshma?
Actually, I mean, in our patient with femoral nerve block, yes, patient didn't complain of any tourniquet pain because it was purely under block. We didn't give any, central neuraxial block. But yes, patient didn't have any pain or discomfort on tourniquet inflation.
Reshma, do you advise your surgeon to apply tourniquet in these patients who are already having diabetic neuropathy?
Sir, but this was like a below knee amputation, and because patient who has like a history of stroke, he was on blood thinners, so they wanted to apply tourniquet, sir.
Otherwise,
But
we,
yes,
otherwise,
but yes, sir. It would be better if they can avoid tourniquet because already patient is having neuropathy, and all these tourniquet can lead to post-op, neurological
you
injuries
are going
as
to
well. Like,
again, you are going to give nerve block, so chances of triple crush injury.
yes, sir. Yes, sir. It is true, sir.
Thank you, Reshma, for your.
Thank you, sir.
Dr. Deepika has answered that it might be because of peripheral neuropathy. With only femoral block, tourniquet pain will be there.
Yeah, the femoral doesn't help completely for the tourniquet pain. So invariably we end up giving little sedation or something like that in the systemic way. If neuropathy, as sir said, tourniquet has to be avoided as much as possible because double crush you never know.
Right, ma'am.
If there's nothing, then we can go for the next case presentation.
Hetal sir, do you have any questions?
No, I think everything is covered. We can move to next presentation.
Right, sir.
Thank you, sir.
Are you able to see my screen?
Yes.
Yeah, Rituja. Go ahead.
Good evening, everyone. I'm Dr. Rutuja, EORA Fellow at Fortis Hospital, Mulund, under Dr. Vijay Shetty, sir. I will be talking about regional anesthesia strategies for radical nephrectomy. My case was a 62-year-old male, 90 kg weight, ASA2, posted for laparoscopic right radical nephrectomy. He was diagnosed with renal cell carcinoma of the right lower pole, known hypertensive and diabetic on medication. Airway examination and systemic examination were within normal, and investigations were within normal limits. The MRI scan showed a 9 by 9 by 6 centimeter solid mass in the lower pole of the right kidney. My plan for the surgery was GA plus right rectospiny plain block plus multimodal analgesia in the post-operative period. After administration of general anesthesia and positioning of the patient in the left lateral decubitus, right rectospiny plain block was performed. We used 0.2% ropivacaine 20 cc, which was injected after in aliquots after confirming the needle tip position with hydrodissection and saline injection. The post-operative period for analgesia, we used a CAD pump with injection fentanyl 10 mics per ml set on an on-demand mode with a bolus of 30 mics and a lockout interval of 30 minutes. Also, injection PCM was added 15 milligram per kg 8 hourly and tramadol 50 milligram SOS. The specimen for this surgery was removed from a lateral extension of the port site incision anterior to the iliac crest. Coming to the rectospiny plain block, it is a novel paraspinal technique which was introduced in 2016. and has a lower risk of serious complications. So the point of injection for the erector spinae plane block is deep to the erector spinae muscle and the thoracolumbar fascia. So the target is between the anterior and the deepest layer of the erector spinae muscle, where we see the spinal nerve roots dividing into the dorsal and ventral ramus, which are targeted in the erector spinae plane. The erector spinae plane block can also be termed as a paravertebral block by proxy because of the location of the injection. The drug can travel forwards into the paravertebral space as well. It is one of the mechanisms, one of the proposed mechanisms of action of this block. The other mechanisms are proposed are that local anesthetic absorption through the thoracolumbar fascia and also by systemic absorption. And immunomodulatory effects of the local anesthetic. So there are other techniques that we use. The patient was positioned in the left lateral decubitus. The midline was identified, and using a linear probe, from the midline we scanned towards the lateral position, laterally to identify the tip of the transverse process. And once the transverse process was identified, the needle was advanced till the tip of the transverse process was hit, and then the injection, after saline hydrodissection, the drug was injected in this plane. Since it was performed at a T8 level, we had to ensure that we were targeting the transverse process and not the rib. So initially, as we can see in this video, this is the squarish transverse process. As we move more laterally, we arrive at the costotransverse junction. And then as we move more laterally, we can see the rounded ribs. And again, we come to the costotransverse junction and then the transverse process. So this, the transverse process was identified, and then only we proceeded to perform the block. Here we can see that as the needle was advanced and the space was identified, small saline injections were given to open up the space, and then the drug was injected in the plane between the erector spine and the transverse process. And the needle was then moved forward as the unzipping of the plane occurred to the proceeded to the next transverse process, that is the T9 transverse process of the T9 vertebra. Advantages of this block were that it is easy to perform. A unilateral block can be achieved with minimal side effects and a lower risk of serious complications like epidural hematoma. There is a reduced risk of pneumothorax and a reduced risk of block failure as well, because it is an easy to identify with anatomical landmarks. Also easy for catheter placements and can be performed at various levels due to the extent of the erector spinae group of muscles. These are a few studies that were conducted in Ming et al. Conducted trials in 2020, for which stated that the primary mechanism of action of ESP is the physical spread of the local anesthetic into the paravertebral space. And this spread is gradual rather than rapid, and only a small portion of the local anesthetic enters into the paravertebral space, while most of it remained in the erector spinae plane. The second study was conducted by which to check the effect of ultrasound guided erector spinae plane block in post-surgical patients undergoing nephrectomy. It concluded that the patients receiving erector spinae block for intraoperative and postoperative analgesia experienced less pain in the first 24 hours compared to non-ESP group. Another study conducted by Wang et al. In 2018 stated that the effect of the erector spinae plane block could be partly due to diffusion of local anesthetic into the paravertebral space through the non-osseous spaces between the adjacent vertebra, as well as the communicating branches that feed which acts on the dorsal and ventral branches of the thoracic spinal nerves, as well as the communicating branches that feed the sympathetic chain. And another, it also stated that the intraoperative use reduced the need for intravenous analgesics during the surgery. Another study conducted by Nazia Siddiqui et al. Stated that the procedure involved a paraspinal facial plain block where the needle is placed between the erector spinae and thoracic transverse process, and the administration of the drug blocked the dorsal as well as the ventral lamina. Coming to what is a radical nephrectomy, it is the removal of an entire kidney with the surrounding structures, and mainly it is used to treat larger or aggressive tumors. So there is the nociception in radical nephrectomy is due to the somatic pain which can occur from the incision, muscle or fascia, and visceral pain which can be due to the renal capsule, kidney, ureter manipulation or retroperitoneum. Because of this nociception, there can be sympathetic activation leading to hypertension and tachycardia, risk of atelectasis and impaired mobility in the postoperative period. The surgical techniques that are used for radical nephrectomy are open, laparoscopic or robotic procedures. So other modalities that we can use for this block for analgesia and radical nephrectomies are central neuraxial and truncal techniques. Central neuraxial includes the thoracic epidural and intrathecal morphine, whereas the truncal includes thoracic paravertebral block, erector spinae plane block, or the quadratus lumborum block. Now, the thoracic epidural is a gold standard for open radical nephrectomies, and it provides excellent somatic and visceral analgesia. But it is an invasive procedure. It gives bilateral blockade, and there is risk of hypotension and catheter displacement as well. Coming to the paravertebral block, a study by Yu Zhao concluded that the paravertebral block may provide effective post-operative analgesia in patients undergoing renal surgery, especially in PCNL patients. So most of the studies that were conducted were for percutaneous nephrolithotomy patients, and not a lot of cases on radical nephrectomy were conducted in this study. The paravertebral space is a wedge-shaped space which lies in the lateral to the vertebral body and the transverse process. It is bound by the costotransverse ligament superior costotransverse ligament posteriorly, and the endothoracic fascia forms the deep border of this space and separates the nerve roots from the sympathetic ganglion. So to perform a successful paravertebral block, we have to pierce the costotransverse ligament. Just a minute. So to perform a successful paravertebral block, we have to pierce the superior costotransverse ligament, as just beyond it lies the nerve roots as well as the intercostal vessels. Now, approaches to the paravertebral block can be a classic landmark guided approach, where a point is identified 2.5 to 4 centimeters lateral to the midline, and the needle is advanced till the transverse process is contacted. This transverse process that we contact will be that of the lower thoracic vertebra, because of the angulation of the spinous, the steep angulation of the spinous processes at the thoracic level. And once the needle is advanced 1 to 1.5 centimeters beyond the contact with transverse process, and a small pop is felt, which is that of the superior costotransverse ligament. Now, this pop is not always appreciable like we do for epidural. So it is advised not to advance beyond 2 centimeters. And this technique is not advisable because of the close proximity to the central neuraxial plane. In ultrasonography, this block can be performed in either sitting, lateral or prone position. So the angulation of the probe is such that we want a parasagittal oblique view, but with the probe facing outwards. Because if the probe is facing in parasagittal orientation straightly, the ultrasound beam hits the curvature of the lung and the pleura at a very acute angle, so it becomes difficult to visualize the lung and pleura, which is essential when we are performing this block. So an outward angulation helps us visualize the transverse process as well as the lung and pleura in one line. So here we can see the two transverse processes, the shimmery pleura and the hyperechoic line, which is the superior costotransverse ligament, and the block, the paravertebral space below it. So here we have performed a paravertebral block for a PCNL surgery. So as I said that the superior costotransverse ligament, the pop is not as appreciable and it may not always be seen in ultrasonography. So we can, what we can do is see that the pleura, as we inject the saline, the pleura bends downwards towards the lung. So we can see that in this video, when the needle has approached at a point close to the pleura, saline was injected to see that the pleura is bowing downwards towards the lung. So it was so this was used as a confirmation of the position of the needle tip in the paravertebral space. Another set of blocks that we can perform for radical nephrectomy is the quadratus lumborum blocks. It was first described by Rafael Blanco in 2007. The quadratus lumborum is a muscle that is part of the posterior abdominal wall. So just a brief description of the anatomy. The quadratus lumborum muscle is surrounded by the covered anteriorly by the anterior layer of the thoracolumbar fascia, posteriorly by the middle layer, and the posterior layer of the thoracolumbar fascia encapsulates the erector spinae muscle. The transversalis fascia, which lines the parietal, invests in the parietal subperitoneal areolar tissue, as it moves posteriorly, it merges with the thoracolumbar fascia. Coming to the types and techniques, so there are three types of quadratus lumborum blocks: the lateral, posterior, and anterior QL. Initially, there was a terminology for intramuscular QL block, but according to the ESRA Delphi study, it is no longer a terminology that we use. So the block is performed in lateral position with the probe kept at the posterior axillary line between the iliac crest and the costal margin. So what we see here is a typical shamrock sign, where we see the vertebral body and the transverse process with the three muscles, that is the psoas major, quadratus lumborum, and the erector spinae group of muscles. Now, for the different types of QL blocks that we perform, the lateral QL block, the drug is deposited at the posterior most part of the transverse abdominis aponeurosis, which can be seen as a hyperechoic reflective line in the USG. The posterior QL block is where the drug is deposited between the quadratus lumborum and erector spinae muscle. The anterior quadratus lumborum block, or the transmuscular block, where the drug is deposited between the quadratus lumborum and the psoas muscle. Now, this is a tabular representation of the coverage provided by the various blocks. Now, this was a cadaveric study conducted in 2021 by Christopher Little. It shows the various blocks that were performed in the cadavers of varying sample size, and this table shows the anatomical spread of the dye or the injected to the nerve roots and the facial planes in the primary findings, and the secondary findings note the consistency, reliability, and staining of the block. Next is the intrathecal morphine, which can also be used as for intra and postoperative analgesia. Injection of preservative-free morphine intrathecally has been found to provide profound analgesia with minimal systemic absorption and a superior quality of hemodynamic stability intra and postoperatively. It is easy to administer with no special equipment or preparation required. The analgesic effect is achieved at a lower dose, and it is also associated with decreased use of opioids in post-operative period. There can be dose-dependent effects like pruritus, constipation, and respiratory depression. These are a few studies that were conducted using intrathecal morphine for postoperative pain. So, in the study conducted by Kim et al., 5 microgram per kg of intrathecal morphine was injected, and it was found that the single spinal injection of morphine combined with IVPCA proved more effective than just intravenous patient control analgesia alone. And the results suggest that preoperative intrathecal morphine is more effective and well tolerated treatment modality for immediate post-op pain management, especially in open nephrectomies. The second study by Gupta et al. Also used intrathecal morphine, but along with 1 ml of 0.5% bupivacaine, 200 mics of intrathecal morphine was injected, and it significantly reduces post-operative morphine requirement and post-operative pain scores after laparoscopic and robotic nephrectomies. Another study was conducted using to compare the use of intrathecal morphine and unilateral subcostal anterior quadratus lumborum block for postoperative pain and laparoscopic nephrectomy. Though it was not a comparative study, it was found that intrathecal morphine injection was provided superior analgesia as compared to subcostal anterior quadratus lumborum block. This is just a tabular format of the various modalities of regional anesthesia for radical nephrectomy, and the target areas that the target areas that are required for the block, the pain coverage that they provide, the surgical approach suitability of those techniques, the advantages and the limitations or risks associated with it. This is an article that was published by Huang et al. In 2025, describing the various regional anesthesia analgesia techniques following nephrectomy. It concluded that with thoracic paravertebral block, erector spinae block, the length of the hospital stay was significantly reduced reduced pain scores within 24 hours. Lateral quadratus lumborum block and transmuscular or the anterior quadratus lumborum block were more likely to reduce opioid consumption within 24 hours. And the retrolumbar, and they were more likely to decrease the incidence of post-op nausea and vomiting as well. Then this was another study comparing the analgesic effects of regional nerve block technique in laparoscopic nephrectomy. This is a meta-analysis conducted by Louis et al. It stated that the analysis of existing evidence suggested that the preoperative quadratus lumborum block was more significant advantages over over other interventions, and it also significantly reduced post-operative opioid consumption in 24 hours. And the incidence of rescue analgesia and post-op nausea vomiting was also extended. The time period was also extended. And other interventions like preoperative erector spinae block also showed potential benefit given, but a larger scale study has to be conducted to conclude these findings. My take-home message is that for any radical nephrectomy surgery, the regional anesthesia techniques do reduce the use of opioid and enhance post-operative recovery. And the choice depends on the surgical approach and the patient profile. Erector spinae plane block and quadratus lumborum block are promising alternatives to central neuraxial blocks. And we have to curate a plan of anesthesia according to the patient and the surgery. These are my references. Thank you. And
thank you, Rutuja. It was a nice presentation. Before we move to discussion, I just wanted to correct your one place. In thoracic paravertebral block, when you are giving it with landmark guided technique,
yes,
after hitting transverse process, you should not go beyond 1 to 1.5 centimeter max. If you go 2 centimeter, you will definitely puncture the pleura. So for thoracic paravertebral block, it is 1 to 1.5 centimeter. And if you give lumbar plexus block, then it is 1.8 to 2 centimeter. But for thoracic paravertebral block, it is 1 to 1.5 centimeter. Over to you, Shishir and ma'am.
Dr. Manjula, please.
Yeah. Yeah, that was a very good presentation, Rutuja. Just wanted to say the summary of the table. Can you just go back to the summary? It is nice.
Yes.
The last but one, I think.
This one, ma'am.
Yeah. So given a choice in this patient, no, you said this is a patient for radical nephrectomy.
Yes, ma'am.
Okay. Was the patient on any antiplatelet, anticoax or anything?
No,
Yeah.
ma'am. Patient was not on any anticoagulation medicines or any
Okay. If the patient was on, because diabetic and IH is quite common,
Yes.
is there anything specific that you would like to change your anesthetic management in these patients?
Because the patient was diabetic and hypertensive, or
If there was any antiplatelet, anticoax?
No, ma'am, I think I would still prefer giving an erector spinae plain block as compared to the other.
All right. So, because why I'm asking is that we have to remember diabetic patients more are prone for a lot of serious complications, IHD being one of it. If they are like, one of the patient having a PTC in the last presenter slide like that, there will be on anticoagulation. So when you're thinking of a central neuraxid block or a deep block, remember if they are on anticoagulants, there is a restriction as per your ASRA guidelines, how, when to stop has to be remembered. So again, between thoracic epidural and the QL block, which covers both the somatic as well as the visceral, these seem to be better than just the ESP or a or a tab block, isn't it?
Yes.
And paravertebral always has some danger, and you have to be having a lot of experience also with a pleural injury.
Okay.
So that's why I asked, will you still go with ESP alone?
Okay.
Okay. Otherwise, I think you've kind of covered of all the things. It's important, I think, for those who are listening that the way she broadly classified them into central neuraxial methods, which is thoracic epidural, plus the use of intrathecal morphine versus a peripheral truncal blocks like, the ESP and the QL. She didn't cover the TAP, but TAP just takes care of only 40% of the pain relief, more so because it takes care of the somatic and not the visceral component. Multimodal analgesia becomes a say because all this just still takes care of less than 60% of pain relief. The other has to become a multimodal analgesia. And that's the reason I guess you use the IVPC, isn't it?
Yes, ma'am.
Okay. So,
Pooja,
Yes, sir.
on your slide, you have combined CAD pump along with the tramadol SOS. What
Yes.
was the purpose of the adding tramadol SOS when you have already given the PCA pump in your patient?
So, sir,
Is there any advantage of combining two type of opioids?
not so, sir, for the CAD pump, we had put the patient on an on-demand mode. So the lockout interval was a 30-minute period. So
30 minutes for fentanyl.
yes, sir.
That was pretty long. We usually set around 8 to 10 minutes for fentanyl,
Okay, sir.
and we only give patient control demand. We do not set background infusion.
Okay.
Secondly, what are the innervation? What are the dermatomal involvement for this surgery?
So, sir, depending on the type of surgery, the type of approach that is used for open nephrectomies between T8 to T10, L1. And for laparoscopic or robotic surgeries, usually it is the more painful is the port site incisions that are taken.
Okay, but what are the nerves which you want to block in this patient?
So the dorsal and ventral rami of the
No. Root values.
So from T8 to L1.
Okay. So in your patient, you gave this ESP block at the level of T8.
Yes, sir.
So do you think it will spread up to L1?
No, sir, not till L1. We could have gone 1 or 2 levels lower at T10 or T11, so that we could have had a rostral, caudal, and cranial spread.
What is the nerve supply of the kidney?
So from
Celiac plexus and aortic plexus.
sympathetic and parasympathetic.
Sympathetic is more important. Sympathetic is more important basically because pain is carried by sympathetic fibers. Yeah. So you need to address this sympathetic fiber as well. So, uh, and do you give unilateral block or bilateral block?
So, sir, we have given unilateral blocks only. I have not personally done or seen a bilateral erectospinal block.
So, which what is the incision in your patient from where kidney was extracted?
Sir, it was the lateralmost port site was the incision was extended more posteriorly to extract the specimen.
Otherwise, most common site is the financial.
Pharyngeal incisions. Yes, sir.
For what? For this purpose, unilateral block will not be sufficient, I think.
Yes, so we'll have to perform a bilateral.
What we usually do in our hospital, we usually one side we usually give QL block or paravertebral block,
Okay.
and another side which is the dependent side, we give ilioinguinal or iliohypogastric block.
Yes, sir.
So what if this IVC is also involved in radical nephrectomy cases? If IVC is also involved, what will be your choice of an anesthesia? Analgesia.
Yes, sir.
Oh, sorry, IVC is, if IVC is involved, what are the problems? What will be your regional anesthesia choice? And how will you manage?
For involvement of the, I will say, so a 4-quadrant tab block or I'm not.
That's okay. You can give 4 quadrants QL block because incision is quite long.
Yes, sir.
The main issue with the IVC uh, extension of the tumor that it reduces venous inflow. Okay.
Yes, sir.
So, like cardiac output will be reduced in this patient.
So sympathetic blockade is what we want to avoid. We would want to.
Venous return will be decreased and the SPB will increase. So in these patients, if you give epidural during the surgery, there will be risk of hypotension.
Yes, sir.
So, but if you want, in lot of patients, we need to put epidural. But during surgery, for analgesia purpose, we usually use opiates. We usually skip local anesthesia agents during the surgery. We usually charge with this epidural catheter. After completion of the surgery, we usually charge with local anesthetic, not before that. Okay. And one thing which you mentioned, the intrathecal morphine is associated with the pruritus.
Yes, sir.
So how do you manage this pruritus? Have you given intrathecal
But
morphine?
I have not used intrathecal morphine, and
We usually give intrathecal morphine, especially in those patients who cannot afford ultrasound machine charges, needle charges, and those who are poor. In those patients, we generally give intrathecal morphine. So this pruritus and urinary retention it is a very common problem associated with intrathecal morphine.
Okay.
So usually the drug of choice is naloxone, which is 40 microgram per hour infusions. Okay, but we in our setup we generally give nalbuphine 3 milligram. Single shot nalbuphine 3 milligram. It is very wonderful drug to manage this pruritus. Okay. And one thing which, what about your when this radical nephrectomy is from left side or right side? Is there any difference in the management?
Yes, so the left side, the kidney is at a higher level. So our level of giving the blocks will be at a higher up, higher thoracic level than the lower.
Sometimes, not only this, sometimes there are few surgeons. They usually cut the rib as well, 12th rib.
12th rib as well, yes, sir, during the surgery.
So in those patients, I think ESP block will not be sufficient. Paravertebral block will be the first choice in these patients where surgeon is going to cut the rib.
Yes, sir.
So, Hetal sir, any question from your side?
Just to add on, the newer thing that has come up with QL block is this at the level of superior arcuate ligament.
Yes,
In
sir.
the last meta-analysis that you showed, no, that Minerva article.
Yes,
So
ma'am.
that LSAL stood for that, superior arcuate ligament block, it is called. Basically, this is just depositing the drug anterior to the QL muscle and superior to the lateral arcuate ligament. So when you deposit in between the gap of the QL muscle and the diaphragm, the local anesthetic apparently is kind of bypassing the ligament and spreads more effectively into the thoracic paravertebral space. So there's a newer thing that has come up.
Yes, ma'am. They
the
use
last few days. Yeah.
higher up QL block, like
Yeah, so like where sir is saying, the paravertebral is a good one. So maybe if you're looking at peripheral blocks, the QLB, the LSAL may be taking a role with the thoracic epidural.
So, any other question from any fellow or?
I think Akash had written some 30 ml of 2%. Anything you wanted to say that I didn't understand what you meant. 30 2% lignocaine, 600 mg has said, but I thought she had used 20 mils in her ESP.
Yes, ma'am. I had used 20 mics of.
So I don't know why he put that question.
Yeah. Yeah, Vandana ma'am is asking whether nalbuphine is given IV.
Yes, ma'am. 3 milligram IV. Basically, 10 milligram ampule we dilute and make it 1 milligram per ml. We prepare 1 milligram per ml and we usually give 3 milligram. And it is wonderful drug to treat this pruritus. And the best part of nalbuphine, because it is a partial agonist as well antagonist. So it will block mu receptors, but K receptor will not be blocked.
Okay.
So some analgesic action will be there even after the reversal of the opiates.
Okay, yes.
So Dr. Kavi is asking use of IIH and IIN. What is that, Kavi? You can, hello? Hello?
Yes, ma'am. Good evening, ma'am.
Yeah, what did you want?
No, ma'am, I didn't get the point of sir telling iliohypogastric and ilioinguinal nerve block for
Or
this
only
case.
finishing incision, which is midline, which cross midline and it goes up to another side.
Okay. Okay, sir.
Okay. So only half of the part will be covered by the QL block, but for rest of the incision, either you have to infiltrate the wound infiltration is required, or you can add this ilioinguinal.
Okay. Okay, got it, sir.
Hello, this is Dr. Sajna speaking. I think somebody was raising the issue about lignocaine giving at 30 ml. So even 20 ml would actually cross the toxic limit in an average patient. So I don't know what this patient's weight was.
Yeah.
So 400 milligram, if you calculate it, comes up to 6 milligram per kg.
Yeah, 2%
So I think that,
lignocaine unlikely you'll be using, no, Sajana, ESP. You'll go with the
no,
longer,
I
yeah.
know, but I think that was what was mentioned there, and
Yes.
she told she used 20 ml
Yeah.
I use 0.2% of ropivacaine, 20 ml for the.
for the block. Okay. But why did that particular thing about 2% lignocaine come? I was not sure.
When I was not sure about it.
Okay.
But I think, as Madam said, Sajana Madam has said, be careful on the volume and the concentration and the dose of the drug that you're using. So whether it is going to be with multimodal analgesia, invariably there'll be a GA.
Mhm.
So you can, if you're looking at bilateral, then I guess you have to increase the volume by diluting the concentration.
Concentration. And better to avoid lignocaine
Yeah.
plain. I think that has been discussed in various forums now. I think few of articles have also come out using lignocaine, especially non-anesthetic areas like where they're doing other procedures where surgeons are infiltrating. That is where we will not be having a watch exactly on what they're doing. So possibility of toxicity is high, and we should keep a close watch on what exactly they're taking and giving.
Okay.
So anyway, role of regional anesthesia is very important for nephrectomy patients because we usually do not give NSAIDs in these patients.
Yes, so we avoid nephrotoxic drugs, so insects are also avoided.
There's another block that I have been doing recently, transversalis fascia plane block. And it has also shown to have a good effect, especially in this I've been doing in donor nephrectomies. So we've been doing transversus abdominis plane block usually, and few of the cases I've started giving the transversalis fascia plane block. So I would like to know if others have used these blocks for these kind of surgeries.
Ma'am, for recipient, which block do you offer in your patients for kidney recipients?
For kidney recipient, we have been doing rectus spinae block.
Okay.
No, I have not done any transverse facialis for this either.
Okay. Anybody else has any issue with transversalis fascia? Tab block, of course, like Madam Manjula told, we're not covering the visceral pain. Same thing will apply to this also, but what I have seen is patients are quite comfortable with the transversalis fascia plane block. Okay.
Usually in my hospital, what we do for the recipient patients, for recipient, we usually give 12 block, and sometimes my surgeon extends incision right up to the right subcostal area, sometimes in few patients. In those patients, we add another block, which is external oblique block, along with the QLB, with the reduced doses, because reduced concentration, because in these patients, especially with the renal compromised patient, chances of toxicity is very high.
Anybody has any other questions?
Yes, can I add something? Shishir, so for external oblique, what volume and concentration are you using in these
10
cases?
ml 0.2%, 10 ml 0.2%, ma'am, only.
10 ml 0.2%. Thank you.
Thank you, ma'am.
May I make a point, Dr. Shishir, please?
Yes.
This is Dr. Vijay Shetty. Just excellent points that you put up. I think I just want to reiterate those for the benefit of the students. One is that just because you put in an epidural or a catheter doesn't mean that you have to use it right away with the full concentration that you would otherwise use in patients like in whom you'd expect a high-grade tumor, which is, sometimes IVC tumor, into the tumor, it goes up to the liver, and sometimes just up to the where the IVC enters the heart even, and those are the most dangerous patients. Also, in cases like where you do a CRE or a high pec surgeries, also you don't start the full power of the epidural at the beginning, but save it for the end. It will make your life much easier in the first few hours of the operation. And the second thing, yes, and the second thing I want to say is about the nephrectomies. I really want to also highlight and sensitize our students that whenever there is a renal transplant, this is a very high-end games with a lot of medical legal implications. So whatever we do has to be properly thought about. These are not patients which we can put in something that is not standard. Number one, always discuss with your seniors and get their approvals to putting any needle into any of the transplant patients, because a lot of discussion happens if anything were to go wrong for any other reason. All the techniques are then discussed and so on and so forth. So we need to be very careful about these are special patients, the renal transplant patient, donor, and the recipient, as we all recently found out also. Thank you very much for all the points that both Dr. Manjula and Dr. Agarwal put up. Thank you.
Thank you, Dr. Vijay, for highlighting those points.
Hello.
Hello.
Yeah, Dr. Shishir.
Yes, Dr. Deepika.
Yeah, I'm Dr. Deepika from Holy Spirit Hospital. So just wanted to ask for recipients, you prefer QL block, but which one? Like lateral, posterior, or anterior?
Anterior, always anterior.
And what volume will be?
20 ml, 0.2% ropivacaine.
And if you are combining it with the external oblique, that will be additional 10 ml. That is, that makes 30 ml of total. Yeah. Thank you.
Nothing else? Should we wind up, Sangamitra?
Ma'am, yes, we will go ahead with the Kahoot quiz.
Yes.
There are no extra messages on chat box also. Any fellows want to ask anything else? Any queries? Otherwise, Dr. Rutuja, can you stop sharing? Gaurav
Yes.
sir will share the screen.
Yes.
I hope all the fellows are ready to scan and join the Kahoot quiz. This quiz is a joint venture by Dr. Amrita and Dr. Gaurav Agrawal sir. So once Gaurav sir shares, we will start the quiz.
Hi, hello everyone.
Good evening, Gaurav sir.
Good evening, everyone. Good evening, Manjula. Good evening, Shishir. Actually, I joined earlier, but I was driving, so I could not wish you all. And I have not contributed to this Kahoot quiz. I'm just presenting it on behalf of Amrita.
Gaurav sir,
Is the
presentation also is important.
is the screen visible to everyone clearly?
Yes, sir. Yes, sir.
I hope there are no boxes visible, because sometimes the boxes are there on the screen.
Now we can see the game pin, sir. There are some boxes, but their game pin can be seen.
Then I'll have to hide those boxes. Have the boxes disappeared, ma'am?
Lower one is still there, sir, but it's not disturbing the screen, sir. No issues. Those are coming and going actually.
Sir, I'm unable to see the game pin of the quiz.
I will just share on the group. Wait, just 1 second. I'll just share a screenshot.
Game pin is not visible.
I can see it, sir. Some of the kids are joining, so I will just share it on the group once. Gaurav sir, your Kahoot screen is gone from my display.
Yeah, I was just trying to put it.
Okay. Gaurav sir, shall I stop the recording?
Yeah, we can stop the recording, please.
Thank you.